Mississauga Halton LHIN identified health equity as one of its key values from its inception 10 years ago. And with that, they were getting to know the community, and we serve a very dense population, over 1 million residents, a very diverse community and very different geography within the LHIN. That being said, 4 years ago, when we were starting the development of our Integrated Health Service Plan, our strategic plan for the LHIN, we met with various individuals across the LHIN, across the geography, and really identified the need to focus in on health equity. Our board approved that equity needed to be a key priority area, and accordingly we identified that within our Integrated Health Service Plan and really commenced a focused effort towards advancing the equity agenda. So one of the challenges that we have in providing equitable services or embedding health equity into the program and service delivery that we do within healthcare is the fact that we don't always know where these individuals are. Where are those areas of vulnerability or the marginalized communities? Where are those areas of certain ethnic communities where, again, in order to provide equitable services, we need to do things differently. Data collection helps us in that, and so some of the work that we are doing is to look at some of those pockets and working with other partners, but having that embedded within the data collection with our health service providers will help advance that work even further. It's not about collecting unimportant information, it's about collecting very important information that helps us to reach the people that really need care the most.
It's great to be here to see Mississauga Halton also joining in on this equity journey, going ahead with equity data collection. We can all understand the population we serve better and do better planning for our population.
Has anybody seen this slide before? This is my starting point when thinking about health equity. These are two kids, both in Glasgow, in Edinburgh. 16 kilometres apart, 28 years difference in life expectancy. This isn't, these are two kids, and this is true. Boy from a poor Glasgow suburb in Halton will expect to live to 54, while a boy born in nearby Lindsay is likely to reach 82. So this is a high-income country with a good socialised health service, 28 years difference in life expectancy. And that's my starting point for thinking, how can we decrease the gap between those two? What can we do? $1 Million Murray was it was a true story that was written up in the New York Times. This was a homeless man in his 50s or 60s who also had physical problems and alcohol problems. And they worked out that over a 10-year period, they spent over $1 million in hospitalization, in emergency services, and him sort of coming in and out of care. Partly because he was homeless, didn't have case management, didn't have anything. $1 million. When they worked out how much it would have cost if they'd have housed him, so they'd have sort of met his needs, they'd have had services that meet his needs, they found that they'd have saved about 75% of the costs. So they'd have been running at roughly $35,000 to $50,000 a year on the bad years, and less than that on the good years, to give him a home and to give him supports in his home, and they'd have prevented most of the hospitalizations. And that's what happens if you get it right. If you get it wrong, it becomes more expensive. Okay? More expensive. And so that's the theory that a lot of HealthLinks is built on. If you don't count people, they don't count. And so being able to count people and being able to count marginalized people is one way of making them visible. It's a direct link. Also, if you look at this sort of slide, if you look at this sort of chart, if you don't count people and if you don't count need, you're also incredibly ineffective. So counting people is one way to help us make the invisible visible. It's also one of the ways of trying to get our services in line with what people need, so it makes things work. Equity equals quality. Okay, and you remember when we're looking at that grant, we look at the graph of effectiveness. Equity equals quality. If you don't have your needs and your services linked up, you're an ineffective, probably wasteful organisation. Equity equals quality.
Now, every member and every agency within our United Way says, yes, we have a diversity and equity policy, and yes, we are doing this work, and yes, we are open and inclusive. However, we still have a huge segment of our population right across them, whether it's visible, invisible minorities, whether it's abilities, disabilities, whether it's mental health, whether it's age, whether it's seniors, whether it's newcomers, that are still not accessing programs and services. And if we wanted to be able to roll out that story and be able to say, yes, this is what your donor dollars are doing, yes, our programs are accountable, yes, our programs are responsive, we needed to be able to create a baseline of data so we could then do some comparisons with. We also needed to be able to look at what were the gaps in services, what were the disparities in services. And so how could we do that if we didn't have any of the information available to us?
La plupart des organismes au sein du LHIN de Mississauga Halton ne collectent pas de données sur le langage de préférence dans lequel les clients, les patients veulent avoir leur service. Donc c'est un bon départ pour nous pour pouvoir avoir cette discussion avec les fournisseurs de services.
We are all looking for the same data, and we're all looking for the same data for the same reasons, and that is to increase equity, to provide a better level of service, and also so that we can collaborate and partner with other agencies in the room to make what we do better for the public.
There is much passion, much interest, and much capacity in the system to move the agenda of health equity forward. We're very much encouraged of the idea of building cultural competency and health equity data collection capacity in our LHIN. We have realized throughout the day as we have come along that the importance of health equity data collection and more importantly how organizations can take steps to building health equity data collection capacity and how we as a system can collaboratively support and move the agenda forward.